The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to our webinar. It's called Going Mobile, the Potential of mHealth for Tobacco Dependence Treatment. This webinar is brought to you by Global Bridges Healthcare Alliance for Tobacco Dependence Treatment. Global Bridges is a worldwide science-based initiative to help healthcare professionals treat tobacco dependence and advocate for effective tobacco control policies. You can learn more about the organization and join the network at www.globalbridges.org. I'm Jessica Havlack, and I will be organizing the webinar today. Just a few housekeeping items before we get started. You're all muted for the duration of this webinar, but if you do have questions for Dr. Augustson, you can enter them into the questions pane on the right-hand side of your screen. During the webinar, I'll be sifting through the questions and will pose as many of them as possible to Dr. Augustson at the end. Also, this webinar is going to be recorded, and it will be archived on our website by the end of the week. So today we are lucky to hear a presentation by Erik Augustson, PhD, MPH. Dr. Augustson is the Program Director of the Tobacco Control Research Branch of the National Cancer Institute. He serves on a number of national committees in the United States to improve population-based tobacco control, such as the Department of Health and Human Services eHealth and mHealth Cessation Interventions Committee, Smoking Cessation Subcommittee of the Department of Health and Human Services, the National Tobacco Control Strategy Committee, and the North American Quitline Consortium. In addition, Dr. Augustson serves as the federal co-lead on the Smokefree.gov Initiative, which represents the first web and mobile-based cessation resource developed by the United States federal government. So without further ado, here is Dr. Erik Augustson.
Thank you, Jessica. And thank you all for the opportunity to spend a little time talking with you today. As Jessica alluded to, I'm going to be spending the majority of our time together telling you about the Smokefree.gov initiative and various pieces associated with that. And in particular, I'm going to focus on the SmokefreeTXT program. Let me begin, however, by acknowledging the fact that the Smokefree.gov team is a large group of very talented young professionals, and I have the honor of serving as the co-lead on this. And I can tell you right up front that one of the real tricks to successfully engaging these emerging technologies as potential platforms from which to deliver smoking cessation is to try to work with people that are half your age. That turns out to be a pretty crucial factor, especially for people like me, who are what are referred to as digital immigrants, or people who grew up in an era when these kind of resources were not ubiquitous, versus digital natives, which are people who, for pretty much their entire life, this is the ocean they've been swimming in. I want to highlight a couple of people on this list. One of them is Dr. Yvonne Hunt, who is the co-lead of the Smokefree.gov team, along with myself. And then I also want to make sure to acknowledge Shawnee Taylor. Shawnee is the project manager for the overall Smokefree.gov team, and so she has the unenviable job of trying to herd all of these squirrels and keep us moving forward in an effective manner. So what I want to spend the time talking with you about today, these are the four topics that I'd like to cover. I'd like to talk a little bit about the potential of mHealth specifically as an intervention platform. I'm going to provide you with an overview of the Smokefree.gov project. Like I said, I'm going to focus on SmokefreeTXT, and I want to provide you with a couple of domestic and international case studies specifically associated with SmokefreeTXT. So some of this information is probably familiar to those of you on the phone, although it may be new to some of the other folks. But I think it's very much worth highlighting because it gives us an important foundation from which to really be considering why are we even bothering with the emerging technologies as a cessation approach. So the figures here are actually a little bit old. They are the most recent figures that we have available to us, but they're now like almost a year old, which in the world of emerging technologies makes them almost like ancient history. But I think they point to a number of very important issues for us to be aware of. The first of these has to do with mobile subscriptions. So what we're talking about here are subscriptions to cell phones. Within the United States alone, we have 234 million cell phones. Now, one of the things to note here is that these are not necessarily 234 million people who have these. So, probably true for a lot of the folks on this call, you might have, for example, a work cell phone or a work BlackBerry, and then your own personal phone. We see that even on a bigger stage when we consider the worldwide mobile subscriptions, which are 6 billion. And again, that does not mean that every person on the planet has a cell phone, but the uptake of this technology has really been just incredible in terms of its penetration. So recent data indicates that 90% of the world's population has cell phone signal access. That means that if they did have a cell phone, they would have access to that, where they live. And 75% of the world's population actually has access to a mobile phone itself. Considering some of the data from the United States, because I think this gives us a nice snapshot to be thinking about on an international level. So among the U.S. mobile consumers, 75% of them sent messages in early 2012, and so that number's actually gone up by now. About 52% were using smartphone apps. About 50% were using their cell phones as a means to browse the internet, and about 37% were accessing social media sites, again, via their cell phone device. And looking at that, there have also been surveys that have indicated that owners of cell phones, whether they're smartphones or just regular old cell phones, if there is such a thing anymore, also demonstrate a lot of motivation to try to seek ways to change various health behaviors. If we consider text messaging, again, this is data just within the United States, one of the classic concerns that gets raised has to do with issues of a digital divide. This is not something that we're really seeing in the United States anymore, or for that matter, Europe. And again, this is becoming less and less an issue even on an international scale. And so within the United States, what we're finding is that the use of cell phones as a kind of a core way of communicating with people within the individual's world is very high in populations that have traditionally within the U.S. been difficult to reach and engage. And so, again, data from 2012 indicates that 85% of Hispanics who have a cell phone are using that as a text messaging tool. I take that back. That's actually 85%. I'm sorry. 85% of Hispanics who have a cell phone are using it for text messaging, and then we see some of the other groups. Related to the kinds of things we're talking about today, we are also seeing a real increase in the use of text messaging, specifically as it is associated with health issues, with about 10% of Americans signing up for health-related text programs in, again, this data is from 2012. This is data looking specifically at smartphone ownership. And certainly one of the things that jumps out at this is that in the younger age groups, so here's what we're really talking about is 50 years or younger, we're seeing the majority of adults in the United States reporting that they have a smartphone. So this is not cell phone, this is actually specifically smartphones. And we do see an association of income also having an impact on that. However, I really want to highlight the fact that even in the lower income levels, we're seeing a very high penetration of smartphones. And again, if we looked at the penetration of cell phone data, we would see this even higher. And so again, these kinds of new technologies, emerging technologies, smartphones, the use of cell phones, are really becoming deeply entrenched in almost all populations within the United States. And again, this is a trend that we're seeing occur on an international level as well. As I alluded to a few minutes ago, one of the things that survey data is also indicating is that individuals who do have smartphones are also more likely to be the individuals who are accessing health information online. And in particular, what we're seeing is that young adults and minority populations are using their mobile phone as a way to access both the internet in general, but also to seek health information. And in fact, I think a trend that's very important that we acknowledge is that in particular in low socioeconomic status individuals within the United States, smartphones and even cell phones that are enabled to do internet browsing, those kinds of portable technologies are taking the place of traditional desktop computers and laptops. In other words, a lot of these low-income populations are using their smartphones and cell phones as the primary means and often the only means by which they access the internet. So there's a lot of potential here for us to be using these kinds of devices. And if you think about it, in particular with low SES populations, this makes a lot of sense. If your housing situation is unstable, if there is the risk that you may move into an apartment and then sometime within the next 4, 5, 6 months lose that apartment because of income instability, if you, in the old days, you had a landline and you would lose that landline, so you would lose that telephone number. And if you had a computer, you would lose access to the internet. But with the use of cell phones and smartphones, even if you lose your house, you still have your phone. And that phone number is portable, so wherever you are living, that number is still linked to you. One of the classic stories that many of you probably see within your own cities, for those of you who live in urban areas, is within about a mile of where I work, there is a major street intersection where every morning there are homeless people who are panhandling for money. There's sort of a classic, or I should say there's a standard group who typically work that particular street corner, and they kind of rotate who's there on a given day, but they're very predictable who will be at that corner. In the 4 or 5 people who normally work that corner, 3 of them have cell phones, and I have seen them talking on their cell phones while they were begging for money at the same time. So again, the cell phone penetration reaches even into populations like homeless populations. Now, that's not to say the cell phone penetration is ubiquitous across all groups. There certainly continues to be variation. However, again, this concern about a digital divide is rapidly becoming a non-concern. So we have this technology that is very widely used. And in thinking about what kind of opportunities does that offer us as public health professionals, I think that there are several key points for us to keep in mind. So the first one is kind of the classic one that leaps out at us, and that is the reach. With the penetration of these devices, the potential to reach audiences that are 10 or even 100-fold greater than what we could reach in typical public health projects and initiatives and treatment campaigns is the kind of thing that's very easy to almost get a little bit starstruck by. We can, if you think about that 234 million cell phone subscriptions in the United States, and you can start to just imagine huge, huge numbers. So although I do think this is an important facet of mHealth, I really think that in a lot of ways that's not really where we're going to get the bang for our buck. And as I already alluded to, we're seeing the opportunity to reach into underserved populations as well. Where I think we really can get the bang for our buck, where I really think these technologies have the potential to be game-changing, is not so much in terms of reach, but is in terms of engagement. And so here what I'm talking about is the ability to use the functionality of these various platforms as a means in which we can both deliver interventions, and in the context of what we're talking about today, smoking cessation interventions, but not just deliver those, but deliver those in a way in which the users become actively engaged in our treatment elements. This has a number of benefits that I think are worth highlighting. So first of these is that they increase the access to the interventions. So again, anybody who has a cell phone can participate in Smokefree.TXT. And cell phones are extremely common. So we avoid a lot of the costs. We avoid a lot of the classic barriers to treatment. So, you know, these have things to do like with scheduling or transportation or child care. I'm a clinical psychologist by my initial training, and so back in the days when I trained to be a clinical psychologist, people would have to come to my office. And so there would be scheduling hassles and how do I get there? And, you know, all of these things are now evaporated in terms of being able to actively engage with the treatment. More importantly, I think if we step back and we consider, again, this issue of the functionality and as well as how these devices are integrated into people's lives, we see some real advantages to the mHealth approach. So the first of these is decreasing what has been referred to as the space-time gap between treatment and behavior. If you come to see me in my office and you and I spend 50 minutes talking about whatever issue it is, depression or substance abuse or smoking, and we explore various issues, we come up with a treatment plan, and then you go out into the world and you don't come back and see me again for a week, maybe 2 weeks. And so you can envision that what this creates is a large distance between when you've seen me and when you come back and see me. And in the meantime, all of the behaviors that we're trying to modify are occurring in increasingly distant time and space from our treatment. And so what this then creates is you can almost envision this as like a sloping line, and in all honesty it's probably an extremely steep sloping line, where the effectiveness of the interaction between you and me in my office rapidly falls off. So when we're talking about the use of eHealth and mHealth, we can find ways to substantially reduce that. And in fact, because users are now seamlessly integrating these technologies into their life, we can seamlessly integrate treatment into their daily life. We can be in that person's pocket all the time. And this, again, eliminates this space-time gap and also makes it so when the person is facing the challenges associated with the behavior they're dealing with, we are right there with them in that same space and time. The other thing is that we can use the interactive functionality of the device to improve the dose. If we can get people to interact with our treatment more often because of the nature of the technology we're using and what we can build into that, then what we're doing is functionally we are increasing the dose of the treatment that they receive. And then a final point just to give a nod to is that delivering treatment via these kinds of technologies greatly reduces the cost burden on the healthcare system. All right, let's spend a little bit of time now talking. I want to orient you to the Smoke-Free project as a whole before we dive into SmokefreeTXT. So in 2003, Smokefree.gov came to live at the National Cancer Institute. At that time, the initial lead on that was Dr. Jackie Stoddard, who really had a very nice vision of the potential of really trying to take this website and really focus it as a smoking cessation resource. I had the great fortune of working very closely with Jackie from early on in the inception of this idea. So from its very, very beginning, this was really designed to be a treatment resource. It was not designed to be a dissemination tool, although there are obviously dissemination elements built into this. But really the goal was to extend beyond dissemination and develop something that is actually a treatment resource. Over the last 10 years, Smokefree.gov has gone under numerous updates and iterations, and in fact, we will be launching a brand new iteration of the site sometime in June or July, so that's coming up quickly. In 2009, we developed and launched Smoke-Free Women. This was done for a number of reasons, one of them being that we wanted to develop more targeted resources, and smoking women represented a logical opportunity for us to explore. But the other reason was that it gave us a chance to really begin to think differently about how we structured our site and we structured our resources, and that also gave us an opportunity to actively engage in social media. And we were able to do that in the context in which if the whole thing failed and blew up, we wouldn't be damaging our core site, Smokefree.gov. Smokefree.gov gets between 100 and 200,000 visits a month, and so we didn't want to do anything that would create problems with that traffic. 2011, we launched Smokefree Teen, which is a multi-platform intervention, and in 2012, we launched Smokefree Español, which is resources in Spanish language. This slide here gives you a sense of the current scope of the Smokefree.gov project. We currently have 4 websites, multiple social media platforms that we work on, multiple smartphone apps. We have content that is specifically targeted to pregnant smokers, and this is an area that we continue to expand, and we have plans to substantially expand within the next year. I also want to note that we have begun to expand into other health behaviors. Initially on Smoke-Free Women, we have a section that within our team we refer to as the AMPI section, which is the Active, More Powerful You, where we have significantly expanded our resources associated with diet and physical activity and sleep hygiene and stress management skills. And we've begun to develop those resources for the other sites as well. Now, in addition to these online resources that we have and social media resources that we have been doing a lot of work that we're very excited about within the context of text messaging. And again, as associated with the Smoke-Free project, these are specifically smoking cessation text programs. We currently have 3 active programs. We'll be launching another one in June in a collaboration with the VA hospitals. That one will be targeting specifically veterans. We are also in the process in a collaboration with DOD in ramping up and launching a military one. And then we anticipate that by the fall of this year, we will also have a program that's specifically targeted to pregnant smokers. I also want to highlight the Quit Now library, which is a library of messages and the suggested algorithm by which they are delivered that is available on Smokefree.gov, and people can download that and use that for free. And then, as I'll talk about in just a minute, we have a number of international projects as well. So let me begin by talking, giving you a little more detail about the Smokefree.gov, the SmokefreeTXT program. So this is the program that we run domestically here within the United States. We have versions for teens, for young adults, and Spanish-speaking young adult audiences. And this is a bidirectional program. However, the program is automated. There are no humans on our end who respond to messages. The general structure of the program is that it's free if you have an unlimited text program. If you don't have unlimited, then the normal text messaging fees apply. And as a side note, the vast majority of individuals who use text messaging now have unlimited texting plans. The structure of the program is that the user chooses a quit date, and that quit date has to be within the next month. And at 2 weeks before their quit date, they will begin receiving messages from the program that help to motivate and prepare them for their quit attempt. And then after their quit date, they can receive up to 6 weeks of messages. And I should say that the frequency of the messages builds right before the quit date, is maintained at a relatively high level for the first 2 weeks, and then begins to taper across the next 6 weeks. So this core clinical content of 8 messages is fixed and is delivered on a set schedule around the user-identified quit date. There are a couple of other features of this. One of them is that every few days within the program, we query users regarding their mood, their craving level, and their smoking status. So these are assessment questions that are sent out. The person texts back their response to that, and based on their response, they get an automated message. So, for example, if someone responded to the mood question that they were really down, they would receive a message that would provide some motivation, and also most of the messages include an actionable behavioral activation kind of technique, basically something they can do to try to improve their mood. If they reported a neutral mood, they would receive a message back associated with that. If they reported that they were actually in a really good mood, they would receive a message consistent with that as well. Now, in addition, users can text keywords to the system specifically requesting help with common challenges. So if they are struggling with mood, they can, again, text the word mood to the system and receive behavioral activation tips and motivation. If they're reporting craving, struggling with craving, they'll receive tips on how to deal with craving. And if they report they've had a slip and they've smoked a cigarette, they'll receive a message that is designed to try to help them get back on track in being with their quit attempt. This is data from the last year showing you that we've seen a very large rise in our subscriptions during the last year. We currently have about 23,000 people who have signed up for the program, with a huge chunk of those people registering within the last year. And that is likely associated with the fact that during the first few months we had launched the campaign, we didn't really do much active promotion. We've been doing a series of promotions since then, and we're really starting to see some big uptick associated with that. So to date, again, we've had about 23,000 people sign up for the program. About 60% of the people who signed up have been women, and that's certainly very common for engaging a lot of not just cessation services, but almost any health kind of intervention or project. We are seeing a pretty decent uptake in men, though, and we're continuing to try to work on ways to continue to get engagement within men as well. This is data that breaks out by self-reported smoking status at the time of registration, and you'll see that about 80% of our participants are daily smokers. So we seem to be doing a good job of reaching that core group that we really want to be reaching, which are daily smokers. This is data showing you what are the dropout rates from the program. So at any time, people can opt out of the program by texting the keyword stop to the program. And what we're seeing is something that I think is a very, very common curve for pretty much any intervention within smoking that you can imagine. And it's closely associated with the relapse curves that we see from smokers. So what we see is that the vast majority of the people who opt out of our treatment do so within the first 1 to 2 weeks. And again, that matches on very nicely to the relapse curves that we see. And so this is very valuable information for us. We continue to try to fine-tune our libraries and fine-tune our approach. And so we are in the process of trying to identify a means where we may be able to impact the dropout rate that occurs shortly after quit date. Also with the understanding that realistically, no matter what our treatment was, we would probably see something that was very similar to this. But we're trying to work on that. Now, this is data that we are extremely excited about. So these are self-reported quit rates at various follow-up assessment intervals. And I think it's very important when we think about how to interpret these rates that we keep in mind that this is data from the actual service. This is not data from a randomized clinical trial. And so one of the things that we typically see is that randomized clinical trials report higher quit rates than what happens when we release any treatment out into the world. And that has to do with a number of facts. One of them being that participants within studies are incentivized to continue to be involved in the study. Also, people who register for programs are often more motivated to make serious quit attempts than the general population. But all that having been said, we are very excited about this data. And so this data here shows that 1 month, so this is 1 month after the conclusion of the treatment. So at 1 month post-treatment, we have 17% quit rates. At 3 months, we have 13, and at 6 months, we have 11. Now, this is very exciting for a number of reasons. One is that these values are very similar to, and maybe even a little higher, depending on what treatment you're looking at, than if we look at other smoking cessation interventions that are out there. The other thing that is exciting about this is that there have been a couple of well-done large studies in New Zealand and in the United Kingdom that did not appear to demonstrate, although they showed good short-term quit rates amongst people using the SmokefreeTXT programs, they did not appear to really demonstrate that that was sustained over longer periods. And so our quit rate at 6 months is particularly exciting. Now, Although there are positives with this being user data from the actual program, one of the negatives is we're not really sure what to compare it to. So we do know that the quit rates in the general population tend to be under 5%, but at the same time we need a comparison group. And so we are in the final stages of working through the paperwork the government requires us to do large-scale studies, But assuming we clear that final hurdle in a timely process, we will ultimately clear it, but the timing is a little unclear. We should be launching a 3-arm randomized clinical trial of the SmokefreeTXT program in July. Hopefully early July. Again, the exact timing of when we'll be launching that will depend on when we get our final clearance from the paperwork. So what we then anticipate is that in approximately a year from this coming fall, we will have that randomized clinical data. We'll have the comparison groups we can really take a close look at. All right. So all that has been discussing what's going on domestically. I want to take a few minutes to talk about some of the international projects that we're working on and then leave a chunk of time for questions at the end. So I'm going to start by highlighting 2 projects that we have going on within China. As many of you are probably aware, the smoking prevalence in Chinese men is extremely high, and China has over 300 million smokers. That number is a mind-boggling figure if you consider, how do we even begin to grasp that? I think a good comparison is that what that fundamentally means is that the number of smokers in China is basically equivalent to the entire population of the United States. And so that would be equivalent to if every adult and child in the United States was a smoker, that is what the situation would be in China. So very, very large public health burden, both for China and then also has domestic, or I should say international implications as well, because this level of smoking is putting China in a position where they are extremely likely to experience devastating economic consequences associated with the non-communicable diseases associated with smoking. And the World Bank has released some figures analyzing China's situation, suggesting that in 20 years or less, China's economy will be completely devastated by the health impacts if they don't begin to make serious changes in both smoking and diet and physical activity within China. So with that as some background, we have 2 projects going on in China. One of which we have finished up, but I want to highlight a couple of these. The first of these is a collaboration between the U.S. Department of Health and Human Services, the Chinese Ministry of Health, and then Nokia, the cell phone company. This project involved selecting 4 provinces within China that were known to have high smoking rates. We developed a set of health messages. These had to do with the health effects of tobacco use. Specifically for this project, the general awareness of the health consequences of tobacco is extremely low within the Chinese population. We also took the cessation messages from the Quit Now library and adapted them to the context of China. These messages were also translated by Chinese public health professionals, and then we did fairly extensive focus group testing with the messages on Chinese smokers in China. So 8 focus groups were conducted. We did 2 in each province, 1 in an urban setting and 1 in a rural setting. So this project has 2 phases. The first phase involves 250,000 smokers. This phase began not this Monday, but the Monday before. What the individuals are receiving is 10 days of messages that provide information on the smoking or the health effects of smoking. At the end of phase 1, which will very soon be coming to a close, at the end of phase 1, the participants in phase 1 will be offered the opportunity to participate in the smoking cessation trial using the text messaging. Our budget, I'm going to say only, although this number is actually extremely high, our budget only allowed us to provide the services to 8,000 smokers, and the individuals who expressed interest in the program but were not able to take them into the program at this time will be offered a smoking cessation service down the road. This is a 2-arm randomized clinical trial. Both groups receive 1 week of countdown messages to quit day. So these are the messages that help to give people strategies to prepare for quit day. The treatment group will then receive 6 weeks of the smoking cessation treatments, the smoking cessation messages, and then we will do a 1-month and a 3-month follow-up. I am currently seeking funding to pursue a 6-month follow-up as well, but at the moment we don't have that available to us. The phase 2 will begin on April 28th, and so in a little less than a week from now. And the entire project will be finished up by the end of middle of September, with the data being provided to us by early October. Excuse me. And so this is very exciting because what this means is that we should have some very novel and unique results available to us by the early fall. And hopefully we will be getting that out as soon as we can. I want to also talk about a second project that we completed last year. This was done in collaboration with researchers from Emory University and with the city of Suzhou in China. This was a non-randomized demonstration project that was developed as part of the annual quit contest that a number of cities in China do every year, with Suzhou being the group who had requested the text messaging be included as part of their program. In this case, the NCI library was translated into Chinese by local health officials, and they did an abbreviated version of the program, and that reflected the parameters of their annual quit contest. So they delivered 4 weeks of the smoking cessation treatment with follow-up at the end of the treatment. In the contest 665 smokers received the text messages, and about 1,000 smokers who participated in the contest did so without the text message. I've recently received the data from the 1,000 smokers, but haven't had a chance to analyze it yet. But this will give us, in this case, a comparison group to take a look at. But I do want to show you some of the preliminary data. Excuse me. This is data only from individuals who received the text messaging. And within the city of Suzhou, it's, for those of you who are familiar with Washington, D.C., it's similar to that in that there's like a core city, and then there are suburbs outside the city. So in the case of D.C., we have D.C., and then we have Virginia suburbs, and we have Maryland suburbs. And the 2 groups who participated in the text messaging contest would be sort of the equivalent of the people in the Virginia suburbs versus the Maryland suburbs. And what we found is that what I'm going to be showing you are some of the preliminary data from the overall group, and then broken out into the 2 suburbs of Suzhou that presented. So the baseline smoking status was daily smokers at 60%, with one group having about 50% daily smokers and the other about 70% daily smokers. And this is indicative of what we're going to see throughout all this data between the 2 groups. We have one group who is demonstrating lower indicators of nicotine dependence, and the other group demonstrating much higher. Time to first cigarette, about 70% reported more than 30 minutes after when they woke up. And cigarettes per day, about half of the group reported smoking 10 or less, and only about a third, and about a third reporting between 11 and 20, and so the remaining smokers are more than that. So one of the things that we're seeing is that at least within the participants of this contest, the group as a whole is reporting a smoking pattern that's substantially different than what we see in the United States. Now, again, that may be unique to the individuals who've chosen to participate in this annual quitting contest. But in general, what we're seeing are lower levels of the indicators of nicotine dependence. Again, we do see substantial differences between the two groups who participated in the text messaging. Now, keeping in mind that this is only data based on the text messaging group, and it's also at the very end of the contest. So this is not follow-up data per se. But we do have reason to be encouraged. The overall quit rate at the end of 1 month was almost 40%, with the group showing lower levels of nicotine dependence quitting at about 60% of those people reporting quitting versus the other group who had about 20% of a quit rate. So again, this overall quit rate is very encouraging, but we don't have the comparison group to show you at this point, and this also does not represent a follow-up. So you definitely need to take this data with a grain of salt. As I said, I do have the data now from the individuals who participated in the contest who did not receive the text messaging, and am hoping to find some time to take a close look at that data within the next few weeks. Another thing that came out of this that we were optimistic to see had to do with feedback about the nature of the messages. Overall, 57% reported that they felt like they received the right amount of messages. Interestingly, those with the lower nicotine dependence who were also more successful in quitting were more likely to report receiving the right amount of text messages versus the other group. 80% reported that the messages were helpful and useful. Again, we see distinct differences between the groups, though. And about 80% reported that they felt the messages helped to motivate their quit attempt, again, with a fairly sizable difference between the two groups in terms of how helpful they really were. I want to close by briefly mentioning some additional activities that we have going on. One that I don't have listed here is that we are exploring additional collaborations in China similar to what we did in Suzhou, trying to expand that and to link that closely to a growing movement in China in which the private industries are developing smoke-free worksite policies, and which then in turn helps to create a need for smoking cessation. And so we're going to try to find a way to dovetail that expansion of smoke-free work sites with offering cessation services. We have a collaboration with the Healthy Caribbean Coalition, and we'll be launching a pilot study in just a couple of months in the Caribbean to explore the option there. The team has provided technical guidance to the WHO for a project that's happening in Costa Rica. We have an ongoing collaboration in the South Pacific Islands that is unfolding. We are continuing to explore the development of projects within India. Excuse me, and we've also received requests from a couple of different Central and South American countries to explore projects within those countries as well. So I want to close by just talking about some of the challenges. So I opened talking about the real value of these kinds of technologies and their real potential, but there are a number of things that we have to keep in mind. One of these has to do with consistency of cell phone access. I alluded to this earlier on. But there certainly continue to be a substantial amount of the population who have prepaid cell phone plans. And once they use up all those minutes, they have no more minutes for the rest of that month until their next source of income comes in and they can recharge their phones. So although there are people who have access, who have cell phones and are actively using them, that doesn't necessarily guarantee that 30 days out of every month they have unrestricted access or even access at all. Another, like we talked about early on, is that although a huge chunk of the world's population has access to a cell phone, that doesn't necessarily mean it's their own cell phone. And so there might be one cell phone in the family. There might be even situations where there is one in the neighborhood or even one in the village. And so this presents a real challenge to how would we effectively deliver any kind of health intervention if we don't know who's on the other end. Another major challenge that we face has to do with the fee structures of cell phone use and text messaging. As many of you on this call are probably aware, every country has its own fee structure, and the providers within that country run the system differently. So we have multiple providers to potentially deal with, and we also have to be aware of how the cell phone use is charged within that company, because how it's done in the United States, for example, is actually a very unique way of how that's done in terms of other international markets. Populations with low literacy. Obviously, literacy levels are not consistent across settings, and indeed many of the populations we would most like to engage are more likely to have low literacy levels. Currently, what we're using is a cell phone platform, and really true across all of our other eHealth and mHealth platforms, that functionally requires you to be able to read. Now, that doesn't necessarily have to be a particularly high reading level, but it does require reading. So one of the things that we're exploring and a number of other groups are exploring are the potential of using short video vignettes as a way to deliver health information. That technology is available even on low-end cell phone devices, and so this is an avenue that has that needs to do a lot of exploration still within it. And then lastly, although obviously I'm very enthusiastic about the work we do in this area, I will be the very first person to admit that these kind of mHealth interventions are not a panacea. They are not a one-size-fits-all. They are one tool in our toolbox in which we can be trying to expand the reach and expand the engagement within cessation interventions. However, there is no way that they should ever be the only tool that is available. There is still very much a role for quitlines, very much a role for the impact of individual health providers and the impact of face-to-face interventions and all of the stuff that we did back in the good old days. And so one of the things for us to think about is what is the role of mHealth interventions within larger public health infrastructure, and how can we effectively integrate that, and how do we balance the resources that are dedicated to various aspects of a mature tobacco control program. And with that, I am going to stop and have Jessica screen questions. And let me also say, again, thank you for the opportunity to speak with you folks today, and also thank you for your patience and attention.
All right, thanks, Eric. So first, we just have a clarifying comment. We have someone on the call who does research in homeless populations, a shelter in Dallas, and collected data from May 2012 to March 2013, and he found that 61% of homeless individuals have active cell phone service.
Oh, so, wow, that's awesome.
Yeah, so thank you, Michael Bissino. I apologize if I butcher anyone's names. Thank you for that information. And then we have a question about the finding of lower-income people owning cell phones, but whether or not there's a decrease or increase in cell phones within the mental health population.
So one of the things that, now, when we talk about mental health population, so first of all, this is a very high priority population for us to reach. The smoking rates are extremely high within mental health populations. Depending on the data you look at and diagnostic specific, it can be anywhere from, about 50% to 100% higher, depending on the diagnosis. Or it can also be something like, the typical smoking rate in the United States is give or take around 20%. Within, for example, serious mental ill populations, so let's take schizophrenia, the smoking rates are like 80 to 90%. So we don't have kind of one ubiquitous or one kind of one category that fits into mental health. What we do know is that, as you would expect, in serious mentally ill populations, so the psychotic disorders, we're going to find cell phone access to be much, much lower, and also cell phone use to be more sporadic. Now, that's not to say the penetration is zero, but certainly that is something for us to keep in mind. However, if we think about other disorders like depression, anxiety disorders, substance abuse disorders, we find that the cell phone penetration rates are extremely high in those populations. And so, again, depending on how you want to slice that pie and focus on that, that's important data to keep in mind.
Thanks. So we have several questions about what smoking cessation treatment they're using and how NRT and other medications are treated through the SmokefreeTXT. Are participants recommended to see their doctor? Is there information available? How's that dealt with?
So we have a lot of information available on our websites, and so there are some of the text messages encourage people to consider the use of medications. So given that within the PHS guidelines on the treatment recommendations, the medications carry a very strong recommendation. We carry that through within our program as well. Now, we don't discuss specific medications within the text messaging, and part of that is that we are limited to, about 100 characters, so we don't have a lot of space. But we do encourage the use of medications, and we also point them to the resources that are available on the websites, which provide a lot more information about the nature of the medication.
Great. So then we have a question about the languages of SmokefreeTXT, what other languages it's available in, and how messages are adapted to be culturally relevant.
So currently we have messages available obviously in Chinese and English and in Spanish. And the Spanish that we are currently using is, as people I'm sure are very aware, there's not like just one Spanish language, which makes it very challenging to develop any kind of, within the United States, or really on a global level, any kind of like one Spanish. How we have dealt with that is we've chosen and I don't think dialect is exactly the right word, but we've chosen the flavor of Spanish, which is the Spanish that is typically used within the government. So it is one that many populations would not speak in their daily existence, but at the same time they can understand it. It'd be kind of like if we framed everything, using English from the United Kingdom, it wouldn't be exactly how we would use it, but yeah, we could still understand it. The other thing that we've done is we have made a very active effort in the Spanish library to not use slang and colloquialisms. So that is something that we use, for example, in the teen library, in particular in the English teen library. But given the high variability of the different flavors of Spanish, and how it's very easy to have what is incredibly cool and resonating Spanish or slang in one form of Spanish that is deeply insulting in another, we've really veered away from that. How we have handled the translations in these various projects that are coming up and running is we've taken the core library that we've developed at NCI, and then we've worked with local public health officials and local interventionists to, as a first pass through, identify messages that are just plain and simply either inappropriate for that context or not relevant for that context. And then we've had the translation done within country. And so really in our attempts to move this forward in an international level, one of the real keys that we've relied on the projects we've been involved in and the projects that we're in the process of developing is we just absolutely have to have the engagement of people who are on the ground in that country in order to really be able, at least what we think to do, to really be able to develop an effective program.
Okay, so that sort of leads into another question from Georgia Saad, and that is how can we collaborate to bring this to other areas, in particular in the Middle East, but in other areas as well?
Mm-hmm. So we are very interested in collaborating on this. And I should also note that the Department of Health and Human Services and the National Cancer Institute see international tobacco control efforts as an extremely high priority that they very much want to get involved in. Now, and so we are in a situation where we are very, very interested in collaborating. We do face a few challenges. One of them, as I'm sure a lot of the people on the call are aware of, has to do with the increasing challenges we have within the budget climate. And so what this means is that HHS and NCI and myself in particular, my team, we don't have a lot of money currently available to actively be moving forward on the collaborations. However, sometimes money does become available, and again, that's happening unfortunately less and less in the current budget climate. But that having been said, we are very interested in collaborating. We are very willing to provide technical assistance, to provide guidance, to play a role in designing whatever study would move forward. The primary limit that we have right now, like I've said, and I'll say 100 times, has to do with the money that we have available. And then the other thing that becomes a limitation is the staff time. So we, on the one side, very excited to be involved in collaborations, very interested in that. It is a high priority for my boss's 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 boss. But we may face challenges in how to effectively field things as well.
Great.
Oh, and so like
yeah.
the bottom line is, if you have a project you want to talk about, then please contact me and we can discuss. And I should also note that the work that my team and I are doing, there are other people out there who you can also collaborate with. And so there's nothing magic about collaborating with me. I can also help you find other people to collaborate with who are working on this. Let me just throw out two names real fast. One is Robin Whitaker in New Zealand. She's the person who did the very first studies in this area. And another, and she's a very collaborative, very talented researcher. Another very talented researcher is Lorian Abrams at George Washington University.
And if you can't read it on this slide, Dr. Augustson's email is there. It's augustson@mail.nih.gov. And if you can't find it there, you can also get it from the Global Bridges website. He's a member of our website.
And let me
yeah.
stick the caveat that the organization I work for is in the process of changing offices, and so things are going to be a little chaotic for the next week. So if you send me an email and you don't hear back from me, please send me another email in about a week.
All right. Looks like we have time for one or two more questions. Someone is asking, Sumi Ali is asking whether it's effective for school students, especially early adolescents, and what is the most common age of participants in Smoke-Free-TXT?
So at this point, we do have a teen library, and we're actually in the middle of a campaign that has quadrupled our teen participation in the program. So to date, of that 22,000 individuals who signed up, only about 1,000 of them have been teens. But within the last week, we've been doing this promotion campaign that's really taking off, and we now have like 4,000 or 5,000 teens involved. So I can only speak from a limited set of data. The limited set of data we have is showing that, and I should also say that our typical teen is like 16. So they're not really young adolescents, they're kind of in that middle period. But amongst our teens, what we are seeing is what appears to be good quit rates in the program and good 1-month follow-up, but we're seeing high rates of relapse at 3 months and 6 months. Now, again, one of the things to keep in mind is what is the appropriate comparison group. And we know that within adolescent smokers, the relapse rates are even higher than what we see in adult smokers. So, again, keep in mind that in adult smokers, those people who are not actively engaged in a treatment program, the relapse rates are like 95% or greater. And we know that within teens, they're even higher than that. And so although we're not super jazzed about what our quit rates are at the 6-month follow-up, we do have reason to believe that they're higher than what would have occurred in the absence of treatment. Now, that having been said, the quit rates that we're seeing, so we're seeing at 1-month follow-up, we're seeing quit rates in the teens, and again, this is based on limited data, quit rates of about 10 to 12%, and then we're seeing those quit rates fall off to, at 3 months and 6 months, to being about 5 to 6%. So not really where we would like to see them, but we do have some reason to be optimistic. So at this point, how I feel about our team data is we do appear to be doing a good job of initiating quit attempts. We need to continue to try to do a better job at helping teams maintain them.
All right, and one last question. Jeffrey Shader is asking if the smoke-free text messages are available for tobacco counselors to use with groups, or if there's some program like that.
So there is the Quit Now text library is available for free on the website, and so you could download those messages and use them. And assuming if I'm understanding the question correctly, relatedly, again, the program itself is free, and so if someone was running a group and they wanted to encourage everyone in that group to sign up, that could be a common resource that all the group members would be receiving as part of the group therapy or the individual therapy that they were undergoing.
All right, and I know I said that was the last question, but I have one more. That is, which WHO regions seem to be the most promising for further expansion based on current cell phone usage and their use for health information?
Right. So I think that the two WHO regions that are really ripe to move this forward, well, okay, so the two that come to mind are those that occur within Asia, broadly defined, and those that occur within Central and South America. Those seem to me to be areas that have, and let me also say this is speaking in very general terms, but in general terms, those are two areas that tend to not have a very strong smoking cessation infrastructure. And again, it's going to vary a lot by country, but speaking in broad terms, these are areas with high smoking rates and a limited available cessation resources, and so they also have high cell phone usage, and so that strikes me as the perfect storm for a place where a cell phone-based intervention could really have a big impact on public health.
Great. Well, thank you very much, Dr. Augustson, and thank you to everyone else for participating and listening in. We encourage you to become a member of our network at www.globalbridges.com. And again, if you had any questions that went unanswered, you're welcome to email Dr. Augustson, or you can send us an email at info@globalbridges.org, and we can get the question answered. So thank you, everyone, and have a great day.
Thanks, everybody.